Well, thank you, Mr. Chairman. As you know, I'm a huge fan of community health centers. I've volunteered in them before. Practicing in rural Kansas as an obstetrician, I had significant interaction with our community health centers. I've tried to visit most of the 32 community health centers that we have across our great state. Another program I think that's been successful is the 340B program. They are certainly profit centers for rural hospitals, any hospital that's using them, as well as community health centers. My first question will be for Ms. Veer, and I'm asking you to explain how the pharmacy benefit managers steal money from the 340B program from the community health centers. As I understand it, and this is based upon community health centers and pharmacists, community pharmacists tell me that the PBMs have found a way to make money off the 340B program by requiring contract pharmacies to disclose which 340B drugs they dispense. And by requiring this disclosure, pharmacy benefit managers shave off a portion of those savings which Congress intended to go to these safety net providers who support vulnerable patient populations.
That is very true, and I can give you some specific examples without naming specific PBMs. But
please do.
There are two major assaults on the 340B program. The first is manufacturers refusing to honor contract pharmacy or 340B pricing at contract pharmacies without us submitting data. When we submit data, that becomes transparent to the PBMs, who then in turn, in order to recoup the rebates they've lost, reimburse for less than what they would for a retail pharmacy. I will use one example because we operate both retail and 340B. It gives me a lens into both. Yep. And for the retail pharmacy, the reimbursement rate might be AWP minus 4%. Mm-hmm. You turn it over to 340B, and it's AWP minus 32.5%. Okay. It's a dramatic reduction in reimbursement that oftentimes when you add DIR fees on top of that, it is below cost.
Yeah. Mr. Chairman, I just hope staff's taking note of this conversation, and this is an issue for a separate hearing. And Ranking Member, I certainly think we need to dive deeper into that one. Next, a question for Ms. Farb. I'm trying to put my numbers together. As far as a payer mix, we saw the dollars and cents, but from a patient volume, most of these clinics probably 60% Medicaid, 25% Medicare. Does that sound about right to you?
I think that's correct, Senator, based on our analysis and based on currently what we see in terms of the patients who are covered, even going up to current numbers. I think it's probably a little bit less, closer to 50% Medicaid and about 11% Medicare.
Okay, and then there's a certain number that would have private insurance.
Right, about 20%.
How many are just literally self-pay, don't have insurance, don't have Medicaid, don't have Medicare?
Sure, uninsured is about 20%, and self-pay is included in that too.
I know, so you got to break those apart for us if you can.
I do not have those numbers broken out by uninsured versus self-payers. So.
Okay. Anybody have a quick guess that runs the clinics? Of that 20% that are self-pay, how many of those actually have private insurance? Half of them?
How many have private insurance? So you're talking about a commercial insurance? Of that
the number of patients that you see in your clinics, what percentage of them might have private insurance as opposed to Medicaid or Medicare?
Generally, it's less than 10% in the state of Indiana.
So of all the patients you're seeing, it sounds like maybe 5% don't have either Medicare, Medicaid, or insurance. I wanted to make that point to you as well. Ms. Veer, do you deny any access to your clinic because of a patient's inability to pay? Mr. Harvey, do you?
No.
Dr. O'Connor, are you aware of any clinics that don't allow access because of their ability to pay?
No, that part is built into the statute around health centers.
So this is what I'm trying to communicate with the chairman is that if financial is not the problem with access to care, if their ability to pay is not the access to care, who's this group of people that aren't getting care then? So you mentioned the desert. We have 32 clinics in Kansas. I would guess that 95% of the patients that don't get health care live within 30 minutes of them. So it's why do patients not get health care that they need and they show up in my emergency room instead? Ms. Veer, what are we missing here? It's more than just throwing money at it.
It is more than throwing money at it, but the investment is really important. For example, I have one family medicine practice that is very in high demand, and it is a 3-month wait to see a provider there. Another thing that we're seeing, I think, largely as a result of the pandemic that we are, coming out of, is more need for walk-in, same-day services, particularly for community members who may not already be established with us. But as we see COVID continue to be part of our lives, they need testing, they need vaccines, they need treatment, and so they're looking to us to provide that. But many of us don't have the resources to do a same-day walk-in clinic.
Great. I'd love to have more answers, but I'm past time. Thank you so much, Chairman.